1900 started neurosurgery and provided the first model of stereotactic apparatus. That was the concept was to get less invasive as possible. And you see here other one, Krause with the subfrontal lateral or supraorbital, Fraser, Cushing, Dandy, and Popper. But let's go to the recent past. Spiegel and Weisses were the first one that really performed surgery in a stereotactic way.
Can we have your slide? Can you share your slide?
You don't see my slide?
No, we don't see.
Yeah, not there.
Sorry.
Okay, can you?
Glenn?
I go back.
Yep.
Can I share the? You can zoom. Let's go to Zoom. Back. I disappear. You see only my face, not the slide.
Yes.
That's a problem. That's the problem. Okay, I may go back. Let's say, okay, let's share the screen. Share the slide.
Okay.
Do you see now?
Yes, clear.
Okay. I go back very fast. Okay, very fast is the beginning of the past. It started from the beginning of the last century with Sir Horsley that were providing stereotactic apparatus, and you see here the master of the beginning of neurosurgery. But the recent past, I think, is very important because Spiegel and Weisses were the first one that provided the stereotactic apparatus for human, and they performed surgery for that. Yashergil, Sami, Konovalov, Apuz, and Spetzler, they are the master of microsurgery, that means microscope. And it was Pernesky actually that introduced the real philosophy and culture of Keyhole, and ISMINS was founded in his memory. Ghazi was a master and was teaching to almost all the neurosurgeons around the world because he was using the operative microscope, because he discovered something that was already there. That means the system. Sorry, I closed the cerebral system, and he was proposing mini pterional craniotomy, respect of brain tissue, reduction of size of craniotomy, and use of vascular root. That is what Pernesky was proposing later on. Majid Sami was the one that was proposing the very mini frontal craniotomy for anterior-skull-based pathology, and the mini retromastoid craniotomy for posterior enclavus pathology. And he was proposing also the semi-sitting position, quite important. Sasha Konovalov from Burdenko, he was master for pineal region approach, and again, mini pterional approach. So that is the Western world, and this was still Western, but is going toward East. Michael Apuzzo was the master for third ventricular pathology, and Robert Spetzler is very important because he was proposing retractable surgery. That is one of the main problem when you are using keyhole surgery. But Pernesky was a very productive scientist and experimenter, and taught to many of us how to go from the keyhole to go almost everywhere. So let's go to the present. Some example of the present. The first is what Pernesky was proposing. That is the keyhole craniotomy, or the very small craniotomy supraorbital. And you see here what is the technique that is for young residents. And this is quite important. This is a very good study from Zuccarello that was showing the difference visual field when you do a very large frontal approach, when you do the orbitozygomatic approach and the supraorbital. And you see here that the vision is almost the same. So Pernesky was proposing something very intelligent, very, very small opening, and move the eye of the surgeon, move the microscope to cover all the situation. And Ernest Niemi was proposing this approach that is quite similar for aneurysm of middle cerebral artery and carotid artery complex. We did some experiment with a cadaver approach with Manfred Sabicher, and this is quite nice to see with the endoscope. That is something that we can use also in a clinical situation. From how far we can go from this approach. This is a vertebral artery, this is a middle cerebral artery, and you see that the volume of vision is very, very important. The limit are almost from the one side, the ipsilateral side, and after you have to decide when use this approach for experimental pathology. For instance, one case, this is our experience with Five Institute, Besta, Sydney, again, City Hospital in Milano and in Ravenna, and you see here the pathology. And just to show one case, was a gentleman that came because of some problem that was related to this syringe, but the real problem was the aneurysm, and the aneurysm was proposed and clipped through this approach, and that is just to show not the ability of the surgeon, that was myself, but to show the vision that you can have. And you see here the aneurysm, the dissection is as usual. We have room enough to move and to clip the aneurysm. The criticism that when you have a rupture at the aneurysm is not so found, because you see here that you can have the portent vessel and you can close also in case of dangerous situation. This is the clipping, and of course you can do ICG again, and that is the end of the story. And this is the closure. You see here that is quite easy to close, and this is the dynamic, the volume. This is the patient. You see here that this eyebrow is moving exactly as the other one without any problem. Another case, this was a huge meningioma, and I'm not bothering you with video, but that's his pre and post. And this is the lady, and you see here quite, and this is the video just to show you that the approach is always the same, and you can use also some very important tool like ultrasound aspirator, and you can perform the surgery. You can use endoscope. That is a case of Charlie Teo, and you can perform all the surgery with the endoscope if you are trained with endoscope. And young people has to know to use both micro and endoscope, because the difference in technically is the same, but the way that you are using the tools is a little bit different, and that is taking a learning curve. But young people are much easier and make it easier that people of my generation, because they started playing games on the television, and they are able to have a coordination completely different from hand and eyes. And in the modern time, we will see at the end that new things require this kind of approach. This is another situation, but let's forget this is quite important. Glial tumors can be done in this way. You see here pre, and you see here post, and of course also some in this case. Oh my God! In this case, tailor dysplasia. So there is a lot of pathology that can be done through this way. Another situation, and this is the preclinical results and the side effect or complication of this approach. And as always in surgery, you have complication because you cannot make any omelets without breaking eggs. So that we are absolutely sure that complications are around the corner, and we try to avoid them. Another keyhole is a natural keyhole, is the nose, transnostril approach for the cellular pathology, particularly for pituitary adenomas, but through Kazam and many others, we can extend the approach, making the demolition of the bone and get also this huge meningioma out without with difficulties, but in a very good way for the patient. I'm not going to show you the video because of the question of time, but the surgery can be done easily, mainly with endoscope, because endoscope is making light at the end of the corridor, and it's quite important to use that. You can use also microscope, but endoscope is doing much better. From the frontal part of the skull base, let's go to the posterior part. Posterior part is the posterior fossa decompression for functional disease of cranial nerve, and Giannetta is the master of that. It was Gardner that started this approach, but Peter Giannetta developed it and making popular this kind of approach. And this is the pre and post. You see here the conflict, and the conflict is gone because the artery is over the way. You hear other vascular nerve conflicts in different situations. And very fast, you see here the characteristic. You see the small incision. You see here the small craniectomy in this case, and through that we can use sharp instrument, sharp dissection, never traction, no retraction. No, is a retractorless surgery. You see here there is no retractor, it's just gravity that is helping you. And here you have the conflict to one side, and one conflict to one side, the small conflict to the other side. And you can move this artery around. This is the first conflict, you see. And you put some, I put some Surgicel, but you can put the muscle, you can put other stuff that has to be absorbable. The Teflon is not so good because it is making many times Tefloma. So this is to show you that through a hole you can reach very important structures that are deep inside of the brain, inside of the skull. And that is the closure. In conclusion, microscope, endoscope, Pure endoscopic, a wonderful tool, but remain a tool. You need an anatomical study to know where to go and which way to choose. Navigation, except in some situation, is mandatory. Mainly if you get inside of the brain, like for gliomas or for other region like pituitary, extended pituitary lesion and extended pituitary approach. The selection of pathology and patient is the key of success, and we have to be very careful talking with the patient and not getting into the error that when you have an hammer, everything is a nail. We know we have to be very expert for Keyhole, but we have to be also careful in proposing to the patient. The supraorbital is, I say, is a very minimally invasive. It's quite very good. It can be fully microscopic, fully endoscopic, or both, and it's very tolerated by the patient. For what is concerning the Keyhole in the posterior fossa or interhemispheric on the IPC angle, this again, a small craniectomy, a small craniotomy are enough to reach very important structure deep inside of the skull. The pineal region, another story, but again, and I have no time to show you the supracerebellar intratentorial approach in which you have a fantastic vision, and recently Schroeder's show that is possible to go with a small borehole and endoscope to treat cystic lesion of the pineal region, and also some very small tumor. In conclusion, minimally invasive surgery, Keyhole surgery via endoscopy is no way to achieve very good results. New way in comparison of the traditional neurosurgery with the large craniotomy, but we have to understand that Pernesky started some 30 years ago, and unfortunately he passed away before find out other way to go in this direction. Learning curve is very long, and it's very important, the anatomical study, and that is something time to spend in the lab is very, very important. Now, the future. The future is quite exciting. Exoscope for all approach is something that is the development of an endoscope. The dexterity, the coordination in between the eyes and hand is the same one of endoscope, but you have a wide field of illumination and vision, and the most important thing is that is ergonomic for the patient, for the surgeon. And after now we have something that is no Keyhole, is a Keyhole without hole, the focus ultrasound for all intracranial lesion. Today is only for functional lesion, but in the next future, it will be also for very small tumors, vascular malformation like avernomas. Radiosurgery is established, is not the future. It will be more precise and more flexible. We will have the intraarterial delivery of drugs through pellets. We will have percutaneous technique developing more and more for the spine and vascular bypass. Very fast. This is the esoscope. You see that everybody is looking to this large screen. It's very easy to work with more than endoscope because we have two hand-free and you don't need an assistant that is working with you. Focus ultrasound, hexablade is the way with focus ultrasound can be delivered to the inside of the brain with the precision of 1 millimeter. Interventional radiology with coning and stenting, we know very well how things are, but when coning and stenting are going in a wrong way, you need to have the possibility to do some bypass. And bypass is coming back via keyhole to make extracerebral, intracerebral bypass for protection of vascular disease like moya, like other disease of the arteries of the brain, or vascularization of the brain. And this is one case. Of course, you need to do the suture in a large situation, but the principle is to get a keyhole to get into the parental vessel and to join the donor and the recipient vessel. And this is one case, again, a large aneurysm of the pericallosal artery, and you can make a side-by-side bypass and to save the function of all the brain for this patient. So, final conclusion, past, present, and future. To survive to different technology, neurosurgery should modify its paradigm. Because the technology will taking over a lot of things, but neurosurgeons are always in the point to be the leader for this new approach. But neurosurgery has to become less invasive, both in cranial and in spine pathology. And spine pathology are quite important. I think that in the future, when we do the next webinar, and we heard that the topics will be endoscope. Possibly we start with the endoscope of the cranial pathology, but we also talk about spine pathology and min-invasive approach to that. Keyhole surgery is more than hand abilities. It's a cultural philosophy. I think that as usually the hands are very important in surgery and mainly in neurosurgery, but it's a kind of mind attitude to go to very minimal invasive approach, and keyhole of Pernesky is one of this, and this is the way. So thank you for your attention.
Thank you very much, Professor Giovanni Broggi, for a very comprehensive and very nice presentation. I think we shall discuss the question and answer session after Asra presentation. Will that okay?
Yeah.
Yeah, we have a good time. So thank you very much. So the next presentation will be from Professor Asra Al-Fauzi. So he is from the University Airlangga, Indonesia, and he's also the president of the 5th ISMINS Congress that's supposed to be conducted this year in 2020. So he also the executive member of the Neurosurgical Technology of WFNS and the secretary of the Indonesian Neurosurgical Society. So Asra will talk about cranial keyhole surgery, the basic principle. So Asra, to you.
Okay. Okay, thank you, Asmi. Can you hear me?
Yes, very clear.
Okay, I will share my screen. So you can see my screen?
Yes, but not the slide yet.
Now, it's okay?
Not yet.
Oh, why? Some problem here. Okay, not yet?
Not yet.
Glenn, can you help me?
Have you opened your presentation, Doctor?
Yes, I already opened.
So go back to the Zoom application.
Okay.
Click share screen. It's the green button on the bottom of it.
Okay. Wait a minute. Sorry. Okay, now.
Okay, we can see it.
Okay. So thank you, Asmi, and thank you, Professor Brogi, for I think the very important introduction about the cranial keyhole surgery. And this time I will talk about the some basic principle and techniques of this kind of approach. As you know, maybe some a little bit story that I think it's related with the philosophy of our recent condition now, that you can see that frontotemporal craniotomy is introduced in 1914 by George Haver. You can see there's a very big opening of the bone and the dura mater. And the first keyhole craniotomy term was introduced by Donald Wilson in 1971. He's the first neurosurgeon to use this kind of term. But the philosophy at that time is very different, you know, that the idea behind it was not simply a matter of just limiting the size of craniotomy. Is very interesting that, but what was based on the principle that a small craniotomy could be rapidly opened and closed. So it's about the timing that small incision and small craniotomy make the, you know, the duration of the operation is decreasing. So this is the old principle before, and you can see this condition. I think most neurosurgeon should be, you know, should be not happening like this, because you can see with small lesion that we have to excise, but we open the whole of the brain. So recently, just with a conventional CT scan or MRI, I think we can measure the, you know, how we can make a incision, how big craniotomy, just with conventional measurement. So I think uh, more and more, I think actually we did the concept of the minimally invasive. Yeah. So you can see here that it's very dangerous that, you know, the best brain protector is the dura mater. We open the dura, so the morbidity may be, you know, increasing with this kind of approach. So we should, you know, change the condition like this. And this is, I think, the concept of cranial keyhole surgery, like Professor Brogi mentioned before, that approach is different from the standard craniotomy because we use a smaller skin incision and a smaller bone window. But the important thing is not about the smaller incision and smaller craniotomy, but it used to be how to limit the tissue oscillation, I mean the brain vessel or the nerve, and also how to minimize brain retraction. So this is the important philosophy of this kind of approach. So the important thing is to, you know, to reduce the possibility of complication during the dissection. And as we already know that Pernesky is one of the giant in this kind of approaches, the keyhole approach. But as you know, in 1997, Dr. Joe, I think from Pittsburgh, already said that the concept of minimalism in cranial surgery is how to minimize the morbidity and associated with the surgical procedure, and to enhance the patient quick recovery. So it should improve the outcome. And you know, the Pernesky and Reis published an article about his 10 years experience in 2005, and he said that you know, the important thing is how to make you know, reduce the approach related morbidity and the short skin incision with the eyebrow, and so the careful soft tissue dissection result should be good in cosmetic result too. And this is, I think, with respect to Professor Mori, he state in Journal of Neurosurgery in 2014 that with a good principle from him, that you can see here that standard craniotomy forms a funnel-shaped surgical corridor to reach a deeper area of the brain. But in contrast, keyhole mini craniotomy form a reverse funnel-shaped surgical corridor that provides adequate working space through a small incision and bone window to reach target. Like Professor Brogi said, that the surgical fit is not different; it's the same. But we can use the the high magnification microscope and use the angel the moving our corridor, surgical corridor, so we can actually can reach even the deeper side of the brain with this small corridor. We can see here that the concept of this approach is that the deep area of the brain can be assessed through a smaller craniotomy, since the intracranial optical fluid widens with increasing distance from the cranial flap. It's very interesting. Even maybe even in the skull base far from the superficial, we should see more surgical fields that we can explore. So this is very important philosophy that somebody always said that how small should be a keyhole. But the keyhole is a concept, not about only the size. If some neurosurgeon try to change the incision before 10 centimeter to 60 meter, the craniotomy size becoming smaller. So he applied the concept of keyhole, because he tried to reduce the morbidity and morbidity of our surgical approach, but with the the same outcome that we use with the conventional approach. So this is the very important philosophy that we have to know. So it's not about size, it's about the philosophy, how we can reduce the morbidity in our surgical practice. So yes, the important thing to do this approach is I usually, for example, for pre-operative planning in aneurysm surgery, so I use the 3D CTA surgical simulation like this. So we can see how could be the operating field with this small window. So we can predict the successful of our surgery, or maybe it should be not used with this approach. We use the conventional approach. So this is very important to do this surgical simulation before we decided to use this approach, because if we choose this approach, we cannot coming back. So we have to make sure that we have capability to do this kind of approach. And of course, it's very important that lately, recently, many instruments that dedicated to this keyhole approach. Some instruments, some scissor, some endoscopic and high magnification microscope, even the clip applicator that designed to make the easier for surgeon to use in this kind of approach with small corridor of the operation. Yes, we already know that many kind of keyhole surgery in cranial area, but you know the most very many use for neurosurgeon is eyebrow approach, or like Professor Brogi said, is retrosimite approach, and also paternal approach. So I will show some case of this kind of approach. The you know actually we are very lucky that the history of our history of this keyhole approach is is had a very long history. You can see in 2005, Pendeski already published his 10-year experience. So we have to say that all the specialty is now going to this kind of strategy to do surgery. Even cardiac surgery, I think is even is still a pro and cons, but some try to do this with the some valve surgery like this. So I think it's very difficult to. So we are very lucky, but the important thing is, we have to open our mind that neurosurgery should be going to this minimally invasive approach too. Yeah. All the subspecialty now is already, going to this strategy. Many innovation, many instrument are, discover many innovation to make the strategy of minimally invasive endo surgery is getting better. So I will notice about this. This is, I think, about the keyhole eyebrow surgery. You can see smaller incision, smaller craniotomy. So this is from Pendeski. I just want to landmarks about the how to do technical about this eyebrow approach. Be careful of the supraorbital nerve, frontal branch of facial nerve, and also the supraorbital foramen. This is a landmark that we have to know before do the surgery. Yeah. Positioning is very important because the position of the operator is very important to achieve optimal surgical access. So please make a self-made preparation. Always with the resident assist, but you have to make some self preparation. Yeah. Sometimes we can use preoperative lumbar drainage or extraventricular drainage to make soften the brain tissue, so easier to go to deeper side. And this is, I always use the incision exactly in the head area, so I'm not using the try not using more bipolar coagulation. If I use it, I use the very small voltage because it can destroy the hair follicle in this area. So this is very important one. And also sometimes we need to drilling the inner edge of the bone above the orbital rim to make our surgical fits more wider. And after sufficient range of the CSF, this dissection of head and middle, so the operating field will be yours. We can go around all the side of our operating field. And you can see here, this is maybe 10 years ago after I started some surgery like this. You can see this is a patient that third day after operation discharged from the hospital. You can see there is some swallow or edema in the supraorbital tissue. So shorten the operation and also reduce the length of the hospital stay in the hospital. This is also the old movie of my patient with this eyebrow approach. This is a IC aneurysm here. You can see this is the clip after the operation. Small incision, one hole here, and you can see the dura mater curvation incision. You can see the base of the frontal, and then you can dissect the arachnoid membrane and see the neck of the aneurysm there. The PCOM was already, you can see there too. So easily we can clip the neck of the aneurysm. So you can see that some case, I think very suitable that we can use this kind of approach. And then after the clip, we can see the third nerve, how to decompress to relieve the ptosis of this patient. And I think you can see the small corridor there. So, and also this is a case. I just want to show you, especially for young neurosurgeon, that there is some, I think, a good case that will be treated with this kind of approach. This is a small case of cranial meningioma with a lady with retroorbital pain that we finally use this kind of surgery to, to remove the tumor totally. You can see we opening the very small corridor of the surgical field. You can see we retract carefully the frontal base, and then we can see the clinoid there, and then we try to open it more arachnoid there, and start to detach tumor from the frontal base. You can see it easily. We can see the frontal base there, and coagulate the base of the tumor, detachment again. So you can see very nice technique using this small corridor of the operation. So totally we can pull out the tumor there. So you can see this is a small tumor that should be easily removed with this small supraciliary. So the other is the keyhole pteral approach. Yes, that you can see the difference of the incision. So the smaller incision just behind the hairlines. And there are many published journal about how to, compare about this supraorbital keyhole versus the cranial craniotomy. Also experience using the paternal keyhole approach in treatment of some canal lesion, and they said that the paternal keyhole approach offer shorter operation times, less blood loss, shorter length of the stay, and improve cosmetic without sacrificing outcome compared with the traditional paternal craniotomy. And I want to show you this movie, but I will not show you all the this okay, small craniotomy there, and you can see this is a case of history of rupture one. Easily we dissect the membrane, and you can see so this is a neck and the dome there. So we make a ICG video angiography. You can see, I think the aneurysm is a thrombotic one. so thrombus inside the aneurysm. So we can clip the neck of the aneurysm there. Clearly we can see it, and then put the clip, and then after that we can cut the dome of the aneurysm, and the ACG after the operation show the good position of the aneurysm, and the branch is okay. So also just like mentioned by Professor Brogi, some cases it's very suitable using this approach. For example, I use this approach for CPA aronid case, or for microvascular decompression. So this is a good indication with this keyhole strategy. You can see here, you can see the opening of the dura is not more than 2 centimeters there, but we can see directly the neurovascular conflict there. You can see even the arachnoid, I'm not opening too much, because I try to this also protect from other lower cranial nerve. So I just concentrate with this point of a neurovascular conflict. So you can see there's 7 nerve there and 8 nerve there. So we can elevate and put Teflon there easily. You can see very small corridor. So easily take out the vascular and put the Teflon there. So you can see the craniotomy not more than 2 centimeters. So I think it's quite good case for this keyhole retrosigmoid approach. So how is the advantage of this approach? First is of course the shorter surgical procedure and less injury to the cranial muscle, minimizing muscle atrophy, require only 1 hole. So it's minimizing poor cosmetic appearance. And always, this is very important, is this approach is with less brain retraction. And of course, the faster recovery and shorter hospital stay. So this again, I just want to show you this unruptured AC aneurysm with a young lady. So you can see the aneurysm is superiorly dome, pointing superiorly dome projection. So it's a good candidate for this approach too. You can see the incision in the eyebrow is, I think, is for cosmetic start for this young lady is very, very nice one. So of course, there is it's very important for young neurosurgeon that there's some limitation with this kind of surgery. First, for me, this approach is contraindicated in patients with massive brain edema. And also, this approach could not be a standard for all neurosurgery pathology. The indication should be strict and rely on the surgeon experience. The keyhole craniotomy may limit the microsurgery working angle, so it is mandatory to use a high magnification microscope and specific keyhole microsurgery instruments. For me, it is preferred not to use this approach for patients with large frontal sinus, because especially for eyebrow surgery, because the greater risk of infection may occur. And this is the future of Keyhole. We know that the general lateral in neurosurgery and all the specialty of surgery has been minimally invasive technique with smaller openings aided with the improved technology instrumentation. The goal of our surgery is to reach the optimal outcome with the least of amount of risk possible. And nowadays, keyhole surgery are more feasible than before because of advances in high-tech tools and techniques. But sometimes, even in my hospital, sometimes there were a contra-argument. Some said that the result from standard approach are good. Why we should change this usual manner? Yes, this is a very important condition that we have to know that, we have to make some innovation. If we can use the good innovation, the more meticulous surgery, more minimally invasive surgery, and the outcome is similar with standard approach. So we have to go that way. The keyhole surgery needs specific instrument and difficult to learn. No, it's not difficult to learn. So we have to, learn with the expert. And there is some instrument that already distribute all around the world about this keyhole instrument, so we can find it easily. And also the argument that it's better to sacrifice tissue and bone rather than brain. So this is the old old philosophy. It's better that we save the tissue, save the bone, and also save the brain to make the good outcome of our patient. So, and then the last one, the principle and technique of keyhole surgery must begin to be taught correctly to our residents, because this technique is a future of neurosurgery. In certain cases, cranial keyhole surgery can be a standard approach to our daily practice. Keyhole surgery is a constant process of evolution. We should continually try to perform less destructive and more thoughtful approaches in our neurosurgical practice. Thank you very much. Thank you, Asmi.
Thank you very much, Asra,
Yes.
for a beautiful presentation.
Yes.
You have shared your thought about the basic principle of
Yes.
cranial keyhole surgery. So with that, we have completed 2 presentations. First by Professor Brogi. He already talked us about minimally invasive neurosurgery, past, present, and future, followed by Asra. But before we continue with the question and answer session, it is our privilege to invite Professor Yoko Kato, the president of ISMINS, to say a few words. Professor Yoko Kato, are you there?
Hi, Asmi. Thank you very much for your for your great organization, and it was very wonderful, the S meeting and also the Congress. And I think that as it means, I think even small educational course should be continuing, but sometimes we should have 1 day or even half day. Such kind of web conference is very acceptable, I think. Anyway, thank you very much for all the members and the participants. Mike, can I ask Dr. Brauchi?
Yes.
Hi,
Yes.
Thank you.
Yeah.
Thank you, my teacher. Thank you very much.
Thank you. Thank you to you.
Your slides. Yeah, your slide was very nice. And I remember all the face, who works so hard for extending the minimally invasive, the history last many years, just like you. I want to ask, because the last slide you showed us some the future of the neurosurgery. How do you think about the exoscope? Recently we have so many technique and so many doctors who are experiencing the exoscope. Do you have any comment on that?
Well, I think that exoscope has 2 advantages. The first advantage is that the light is very good and the visual resolution is very good. The second one is that is the same vision manual concept that you have with the endoscope. So I think that the new generation that are using more and more endoscope will be more prone to use the aesoscope than microscope. Nevertheless, the microscope, endoscope, and aesoscope are tools. So we have to choose following our experience, but also following the particular indication. And I think that Zaza was very good in pointing this. It's very easy to go through a small craniotomy when you move your vision and the channel of the vision. With the endoscope, you are going inside. With the aesoscope and microscope, you stay outside. And the aesoscope is the advantage of making the assistant vision like the one of surgeon. So I think that in the future, it will be a very good improvement on that. Microphone.
Unmute.
I'm so sorry. So I want to ask maybe Asra and also Dr. Asmi, that sometimes when we use the endoscope, sometimes we lose the orientation. So what is the solution? Sometimes we lose the orientation. Do you have any good idea?
Yes, I have no many experience by endoscope. Maybe they'll ask me. Can please?
Well, it depends on where do you use the endoscope. I usually use for transcranial and endonasal. So first, the way you hold the endoscope, you must get your orientation right from beginning. And I always ask my assistant to orientate the view like a clock. You know, I would say number 1, number 2, number 3, that you look at the clock. So that is how it goes. And the camera should go like that, okay? And then that's how we orientate. And sometimes we have to turn the endoscope in order to see a certain corner, but you must remember that either you turn clockwise or anti-clockwise. Then you must reverse back to the original position as you enter. So this is how I think I orientate myself. But most important thing, your assistant also must understand. If you do endoscopic cranial surgery, you hold the endoscope by yourself, or even endoscopy assisted. But if you do endonasal surgery for skull base, usually you need your both hand to do the surgery. You do bimanual, but the scope will be held by your assistant. So there shouldn't be any conflict between the surgeon and the assistant. The assistant should assist the surgeon rather than the assistant sometimes want to see certain area where it's not in the field of the surgeon. So that is a very good, very important. And the endoscope surgery, for example, when you do combine, they are not assistant actually. They are also a surgeon. The one that hold the endoscope must have some idea that if he do surgery, this is how it should be like that. So I think that is I think some clue that I can share. I don't know, maybe we have 14 panel with us, Professor Mori, Professor Kinlan, probably they can share their experience too. I hope that answer your question, Prof. Kato.
Yes, thanks a lot, yes.
Okay, meanwhile, we have a few questions from the audience. The first question from Dr. Afan, addressed to Asra. How do we preserve supraorbital nerve during orbital roof craniotomy?
Okay, yes. You know, we can with our fingers sometimes we can see the foramen of this subductal nerve, and the important thing is not but sometimes we think that if we touch or cut that nerve, it will be damaged. No, sometimes with the retraction, it's also make it a damage. So sometimes I usually try to make 1 centimeters, distant from that area. So my incision and retraction is very, very important to avoid to injure that area. Maybe if only retraction, so maybe it will become, will be healing in 1 month or 2 months. But if we cut that nerve, so it's not good for the patient. So the important thing is not to cut or not to damage that nerve. Also, not to retract much in that area, even the skin. Okay.
So that's a very,
yes,
very good advice.
Yes.
Because sometimes we thought that surgery is the only thing that causes damage, but the retraction
No.
is.
Yes. I have a experience about that.
Okay. Thank you. Another question from Dr. Hade Praja. I hope I pronounced the name correctly. So I think this question should be answered by both speakers. So what are the pros and cons of keyhole surgery for brain surgery? So maybe Professor Brogi first. Pro and cons.
Well, I try to show you the pro. And I tell you that one of the pro is that you can really tilting the table, positioning the patient and tilting the table to have the gravity to make the retraction of the brain, because you have a wide, clean corridor, both in anterior part with the sora orbital, both in posterior fossa, both in the temporal approach. And that is something that you can use when you have a keyhole craniotomy. If you have a large craniotomy, gravity is not working because of the edema of the brain. The con is a culture. So you have to learn how to do, not to be afraid to be looking through the hole. And the best things to do that is to go in the lab and to use cadaveric experience, because at that time your fear is going away, because unfortunately it's not alive, the patient, and you can learn very fast. So are more prone than con.
Oh, very good. So Asra?
Yes, like I saw in my slide, there's some counter-argument. There's some doctors, some neurosurgeons said that with the standard approach, we make a better result. Why we should took another approach that make it difficult? So I said that it's not difficult, as Professor Bogi said. When we learn in cadaver, we learn from the expert, and now many specific instrument for this kind of approach. So it's easy, I think. So I think with this smaller approach, but with with the same result of the ordinary approach, with a shorter operation, with reduce the hospital stay, so I think it's better. So we just need some innovation and try to learn. That's all, Asmi. Yes.
Thank you very much. Yeah.
May I add something about this situation?
Yeah.
I mean, most of our colleagues are afraid of new things.
Yes.
But you have to tell them when they won't change it. How many years have their car? Because if you go back of the 20 years old cars are completely different than new one. And today our hybrid car, electric and non-electric, with power brakes and safety belt and so and so. So in the life of surgery, they have to learn that. That's, I think, the most fantastic argument against them.
Very good example. So we have more question coming up, which is very good. So the next from Dr. Harshad. Yeah. How do you achieve proximal control of artery for temporary clipping during dissection? So Asra first, followed by Brogi.
Yes. Yeah. As we know that some pro cons for rupture case of aneurysm. Yeah. This is the main issue. But there is many published articles so that it is safe. Yeah. Before I always use the ICA neck securing before, but recently maybe I know how to handle, so sometimes I don't need to open the neck of the IC aneurysm. So it's rely on the neurosurgeon, so you can decide whether it's experience, you need experience about this. Yeah. For MCA aneurysm, sometimes we can use some temporal clip, but for IC aneurysm, sometimes very difficult. It's depend on the position of the aneurysm. Maybe Professor Brogi have some experience.
No, I completely agree. And you underline on your presentation that you have to plan in advance. You have to know where is the neck, where is the parent vessel. And I think that is very important. I tried to show in maybe I was very fast in my presentation on the video, that you can expose all the carotid artery. So in case of disaster, you can make a temporary clip of the carotid. But the big problem is that to clean the aneurysm and the parent vessel, the passing vessel, and to be sure when you put the clip to see exactly where you put the clip. And the room is enough. I don't think that it's important to have a special instrument. The only special instrument actually is the clip positioning, because that is, you have to something that you can bend to malleable clipping, because but that's because of the size, not because of the size of the craniotomy, because of the anatomy of the aneurysm. So that's my comment.
Thank you very much. So next question from Jumasri. Okay, so to both speaker. So is there any chance that this minimally invasive keyhole approach change to open surgery? Means do you convert from a keyhole to traditional craniotomy? So do you have any experience?
Me first, okay. Yes, I just saw you in my slide deck. Pre-operative, diagnostic is very important. Pre-operative preparation. So we have to, make a good diagnosis that this kind of lesion is, is a good candidate or available to use this approach. Because in my opinion, if we decide to do this approach, we cannot go back. So if you you are not very confident to do this, so it's better to use the standard approach. So I never have experience to do that. First, I use this keyhole, and then I move to make a standard approach. So because the pre-operative diagnosis and planning is very important. Thank you. Maybe Professor Brogi have some experience.
No, I completely agree. You have to plan in advance. You show for instance, the tuberculum cell meningioma. Before opening, you have to know the relation of the meningioma with the vessel, and with the standard MRI you can, and angio MRI, you can have that. And if you need, you can make an angiography. And after you choose if to do peritoneal approach or E-Brown approach. And I think that is very important. But that is very important for any kind of surgery. There was a time in which there was no navigation, and there was no MRI, there was no CT, and the surgeon has to be very large craniotomy just to find the tumor, because they knew that the tumor was in that side of the skull, of the brain, but they don't know where. Today we can plan in advance, and there is also virtual surgery, but with the images, but a very good neo-navigation planning in advance is very, very important for every kind of approach, mainly with minimal invasive approach.
Thank you. So question from Dr. Nujaimin Udin. Any role of ventriculostomy when the brain is edematous and retraction of frontal lobe or temporal lobe is rather difficult when you do supraorbital craniotomy?
Yes, yes. As I mentioned in my slide presentation, that massive brain edema is for me is contraindication to do this. So sometimes it's if we see the very tight brain, so trying not to use this approach. But sometimes, or maybe if you operate the very big tuberculum meningioma, some expert usually use lumbar drain first to make the brain is reducing the tight brain. But sometimes, but for massive brain edema, I never do the keyhole approach like this. Thank you. Maybe Professor Brogi have some opinion.
I never use lumbar drainage before surgery. The main problem is that I completely agree. If you have edema and you can see in the pre-op MRI, you cannot go with this kind of approach. Although if you make a large approach, you have edema, the brain is coming out, so like in traumatic brain injury. The first step, anyway, and with the A-Brown approach, is to open the Sylvian system and to get CSF out, and to be very careful in opening the liquid circuits, and to try to deliquate exactly as you do in the posterior fossa. The advantage is that the brain is floating inside of the skull, and you take out the water, and that's okay. If you are in problem, use diuretic drugs. The anesthesiologist has to inject immediately diuretic drugs that are working. In very few minutes, the brain is going down. That's my experience.
Thank you very much for both of you. The next question from Dr. Ariandito Widi. Is there any particular pathology in the cerebellopontine angle where minimally invasive retrosigmoid approach may not be as effective as it is intended?
Yes, yeah, me first. Okay. Yes, actually, for me, some pathology is very indicated to do this keyhole. For example, that microvascular decompression or CPA arachnoid. So very easily to resolve the problem with this approach. But some case of big tumors related to brainstem or many lower cranial nerve there that very encased to the tumor. So I think it's a little bit quite difficult to do with the keyhole craniotomy, especially with big tumor. I think very dangerous to dealing with lower cranial nerve. So, but with small tumor, I think we can very confident to use this approach. Thank you. Maybe Professor Brogi have some experience.
Well, for the retrosigmoid approach, sometimes the limit is the petroclival meningioma, because they are going up, and you have to go also to open the tentorium. So maybe you can do combined approach, infratentorial, supratentorial, in one step or in two steps, because with only one approach you cannot reach completely safely the taking out of this kind of tumor that, by the way, are absolutely benign.
Okay, thank you. We probably we would like to have some comment from the panelists. Maybe Professor Kentaro Mori, are you there? Professor Mori?
Yes.
Okay, please.
Yeah, thank you very much for Professor Brodzi's nice presentation and Professor Faraj's nice presentations. Both of you mentioned about the pros and cons of the keyhole surgeries. But I have about 350 cases of keyhole surgeries. But I think there are 3 times cons than pros. And pros and cons, of course, pros is minimally invasive because of minimum soft tissue injuries. But there are many cons, such as we cannot accumulate enough light intensity in the deep location. And another problem is that keyhole surgery is straight axis surgery. So we cannot manipulate and we cannot observe the pathologies from the various angles. So we cannot manipulate the pathologies in very fine movement. So keyhole surgeries limit us to manipulate pathologies less than standard craniotomy. So I think from my point of view, surgical indication is most important. As Professor Brody said, we have to limit the indication of the keyhole surgeries for the aneurysm and tumors. Because once something happened, keyhole surgery suddenly changed to the maximum invasive surgeries. So the best thing is, as Professor Brody emphasized, that we have to choose the patient for the keyhole surgeries before the surgery. So we do not insist in the keyhole surgeries, because nowadays we have a lot of other tools, such as gamma knife surgery and endovascular surgeries. So we do not need to emphasis on, or we do not need to insist in keyhole surgeries. But once we can choose, we can properly choose the patient for the keyhole surgeries, it should be very beneficial for the patient. It's my opinion.
Thank you, Prof. Kentaro Mori. Maybe we have Professor Masaki Taniguchi. So are you there? Professor Taniguchi?
Yes, Professor Tani is here.
Okay. All right. Maybe we have Professor Kinlan. So Kinlan, are you online? Oh, he left already.
Professor Armando Basso is here.
Yeah, yes.
Yeah.
Professor Basso, can you come online?
Out there also.
Okay.
Toyota.
Maybe Toyota, yes. Professor Shingo Toyota. Professor Toyota?
He's not active too.
Okay. All right. So there is another, I think, question. Okay, no, it hasn't come out yet. Let me check.
Excuse me, I'm here,
Yes.
but I'm just arrived. I just arrived.
Okay. All right.
Good morning for me.
Good morning, Professor Baso. So
Morning,
please
Professor.
say something. Professor Baso, are you there?
Yes, I'm here, but I come back in a minute. Okay.
Okay, all right. Okay, so we shall continue discussing. So what is your advice to both speakers for the young neurosurgeon? Because we have about 195 participants for our first webinar. So most of them are, I think, maybe a young neurosurgeon from the name that I can see. So how do you choose your case, especially for keyhole approach? So what is your advice?
Yes, yes. As you know that keyhole surgery is one of the future of our neurosurgery. So I think in the future, this keyhole approach is become a standard for some kind of pathology. For example, for microvascular decompression, or for some small tumor or arachnoid case, something like that. But we need to, we need to teach them from now on with the cadaver, so and know the experience from their teacher. And also the important thing, as Professor Mori and Professor Brogi mentioned, that they know the strict indication for this kind of approach, for only for some pathology that could be beneficial to the patient. This is important thing, a message that we have to send to our young neurosurgeon. Okay.
As I tried to explain before, the planning is very important. The use of the new tools for enlight dark spot is also important, and endoscope, it will really improve that one. Young people are prone to use endoscope, and I think that keyhole are really a good way to learn how to use endoscope. The pituitary region is mandatory. No one is using, or almost no one is using microscope to get pituitary region lesions. So these are the advice, and the other advice, as I said, try, and that's you can do also in an anatomical situation.
Thank you very much, Professor Brogi. So I would like to take this opportunity to announce that our 2 monthly webinar ISMIN will be held on the same day, Friday. Yeah, so the next session will be on 11 December, and the topic will be on endoscopic neurosurgery. So I hope everyone will mark your calendar, and please join the session. So there was also a request by one of the participants, a question actually, whether this webinar attendees will receive any certificate. That is a very good suggestion. So since this is the first time that we conducted our webinar, we will look into this matter seriously, and we hope that our team will work on it. Perhaps in future, we will try to provide maybe an e-certificate for those who participate in this webinar. So meanwhile, do we have a Professor Baso there? Because we will finish the session shortly in 3 minutes.
Yes.
Yeah.
Hello.
Yes, Professor Baso.
Yes. How are you?
Very
Fine.
good.
Thanks.
Nice to see you all.
Yes, nice to see you.
Nice to see you all. I'm sorry because I have another meeting before, so I couldn't join at the right time. So, but it's a pleasure to see you all.
Yeah. How are
Thank you.
you?
So the next webinar, when is it going to be in December?
Yes, 11 December, Friday, same time.
Okay, very good, fantastic. Hello, Giovanni. How are you?
I'm fine. You? I'm fine. I see that you're good, in a very good shape.
Yes. I participate. I'm very active. Unfortunately, with the virus, we are really a little bit obliged to be confined. You know, that's a problem.
You cannot fly. That's the problem. He's flying.
Okay. So
No.
So I'm very happy to see that the ISMINS is working very hard, and with this young president, it's a very good group that I love. You know, we are with Giovanni. We have been the founder of this society. So, where is Yoko? Yoko is around.
Hi, how are you? Hi, Armando.
Hi.
How are you? You look very nice.
Fine. Okay. Yes.
Japan is
I'm very
10
happy.
p.m.
I don't see you, dear Yoko. Let me see.
Yes.
Hello.
Hi, how are you?
Hello.
Fine.
Very
you
nice.
look very nice. Thanks.
Yes.
Thank you.
Okay.
Thank you for joining. You are always our teacher. Thank you.
Okay.
Thanks
My dear Yoko, you're very active and really you have so many things to discuss concerning the foundation also.
Thank you.
Okay. See you.
Okay, I think.
Congratulations to all you. Okay.
Yeah.
Okay, thank you.
Thank you very much, Asra and Giovanni.
Yeah, thank you.
Yeah, thank you. Before the closing, about the request of resident to have a certificate, I think that the society may provide an electronic certificate to all the people that are registered.
Yeah.
You have the email address, and send Mr. Dr. such and such participate to the ISMINS webinar. And I think it's quite important because this one making alive the society toward the world.
Okay.
Very good idea. Yes, thanks.
We will work on it, surely.
Yes.
That is a very good suggestion. So just to share with you that we had some discussion before the webinar. So pertaining to the ISMIN Congress that was supposed to be held in Surabaya. So maybe Asra can share with us what was the decision?
Yes, the decision is we postpone this year Congress and then shift to next year. So it will be in the end of the years, about in September or November next year. So we try to make it, combine, hybrid virtual surgery. Maybe if this situation is getting better about this pandemic situation. As you know that until now, we cannot predict how is the condition until next year. So, and then maybe Dr. Asmi can tell us about the future program that we have to, reprogram the schedule. Please, Dr. Asmi.
So we also discuss about what happened to the next Congress, which we should have an interim meeting in China, which followed by a 6th Congress in New Delhi, and another interim meeting in Switzerland by Nikolai Hoff. So we thought that it could be nice to shift 1 year ahead. In other words, Astra's Congress, instead of 2020, we moved to 2021. And then, but in between, we may have more something like webinar or interim meeting. So we will share the conclusion and the summary of the meeting. We will email to the all executive board. Maybe final say from Professor Yoko Kato before we close the session.
Yes.
Yeah. Thank you very much for the first webinar of the ISMINS. I think our future is more and more minimally invasive for the patient and for the brain, for everything. But for that purpose, I think we need more training from the beginning, and also that we should learn more anatomy, and that is, I think, the final solution. We can save the patient's life. And thank you very much for a nice webinar. So we should continue, and we look forward to the second one in December. Thank you very much for your great work. Thank you very much.
Thank you.
So with that words, thank you everybody. Stay safe and keep in touch. See you on 11 December, same time for the second ISMIN webinar. See you again.
Well, let us know.
Thank you.
Let us know. Thank you. Thank you.
Thank you all.
for all the work you have doing, my dear friend.
Yes.
Okay.
Thank
Bye.
you all.
Thank you, sir.
Be safe.
Bye-bye.
Bye.
Bye.
Bye.